Good evening, everybody. Thank you for involving us. We are now in the session, Adult Clinical Practice Symposium, Lipidology, and I'm happy to be with my colleague, Dr. Abdullah Al-Futaisi, we're gonna tackle this session today. Thank you for involving us, and we have four excellent lectures coming on. Dr. Abdullah.
Thank you, Dr. Walid, for your presentation. It's my pleasure and honor to introduce Dr. Ray Gossick. He's the president of European Atherosclerosis Society. He's the professor of public health and honorary consultant cardiologist. He's the director of Imperial Center for Cardiovascular Disease Prevention, deputy director of the Imperial Clinical Trial Unit, and he's of the Commercial Trial Imperial College of London. Please, the floor is yours, Dr. Ray. He's going to talk about heterozygous familial hypercholesterolemia, an update. Please go ahead. The floor is yours.
Well, thank you very much. It's a great pleasure to be here at the Gulf Association of Endocrinology and Diabetes, and to be with you at least virtually in 2021. My name is Kaushik Ray. I'm president of the European Atherosclerosis Society, and the title of my talk today is Familial Hypercholesterolemia from Screening to Treatment. These are a list of my disclosures that you can see here. By way of background, I just really want to remind you that familial hypercholesterolemia is a genetic condition. It's in fact the commonest monogenic disorder that is affecting mankind. It's autosomally codominant, and what it results in is lifelong elevations in LDL cholesterol from birth. So it's got nothing to do with diet and lifestyle. Essentially, the mechanisms by which you remove LDL cholesterol are defective. Now, the global prevalence of this was estimated at being between 1 in 200 to 1 in 300, but we now know, based on systematic reviews and meta-analyses that we've done, published more recently in Circulation, that the global prevalence is 1 in 311. We also know that FH is widely underdiagnosed and undertreated. And we do know that diagnosis, particularly early, and treatment of familial hypercholesterolemia, treating cholesterol, is known to reduce the risk of cardiovascular consequences of familial hypercholesterolemia. And this is particularly important. We established about 5 to 6 years ago the Familial Hypercholesterolemia Studies Collaboration. I'm pleased to say that many of the Gulf countries have participated in this. And this paper was published in The Lancet with this global collaboration in 2021 to coincide with FH Awareness Day, FH Awareness Week, and also the World Heart Day. What do we find? Well, we've established a network of countries across the world representing all geographical regions, 66 countries. To date, we've received more than 66,000 individual participant data in individuals with familial hypercholesterolemia, either through a clinical or a genetic diagnosis. We have children. We also have homozygous FH. The first thing to say is that on the left-hand side, you can see the age of entry into the registry, but also the age of diagnosis. And I want to show you at the bottom. Now, this is a condition that is prevalent from birth. We are only diagnosing about 1.5% to 2% of cases before the age of 18. And that is really very bad. That is too late to start making these diagnoses, because the average age at which we're diagnosing patients is somewhere between the age of 40 and 50. It's about 46 years is the median. So if the global average is 46 years, it means we've just missed 46 years of cholesterol exposure for the vast majority of our people with FH. What else are the consequences of this? Well, look at age of diagnosis and look at prevalence of hypertension, diabetes, for example. These all increase the older you are. So the older your age of diagnosis of FH, the more likely it is you're going to find additional risk factors. What do additional risk factors do? They increase the risk of cardiovascular disease. So getting diagnosis early, before the age of 20, is absolutely essential, because then we have more time to change exposure to LDL, but we also have an opportunity to reinforce behavior and diet and lifestyle, so we can avoid things like hypertension, diabetes. If you look, for example, at the distribution of obese and overweight individuals, that also increases with age, and there's geographical distributions. The second thing is, we often have healthcare systems that focus on the index case, and that's important because we often need to find that first person to be able to find those additional family members. But look at non-index cases. This means a patient presented, let's say, with an MI, that had a high cholesterol, I suspected FH, I screened the family. And then I found non-index cases of FH, meaning I found them through cascade testing. In non-index cases, the prevalence of coronary disease or premature coronary disease is much, much lower. So this shows you the importance of cascade testing, but it also starts to suggest to you that actually maybe we should move away from cascade testing to universal screening of cholesterol. Because if all I do is find people earlier, there's going to be less disease. So that's another important key finding. The next thing to consider is, what do I do when I find FH? Well, when you find FH, we are, as you would expect, treating people with statins. But remember, most people have an LDL receptor mutation. They have one defective gene, one normal gene. Therefore, it won't function as well as in other individuals in terms of response to treatment. So we need combination treatment. But look at the use of ezetimibe. Only 24% of people were using ezetimibe, for example. Look at the use of MABs. It was only, PCSK9 inhibitors were only used in 3% of individuals. And if you look at multi-drug combinations, it's actually really low. But what we find is, for goal attainment, for example, these are the proportion of people achieving goals. We should be achieving, if I miss a diagnosis of FH and I'm only diagnosing people at the age of 46 and I've missed 46 years, they will have more subclinical disease. So at that point, I have to treat them more aggressively. But look at how well we're doing with goal attainment. It's really very poor. Less than 3% get to below 1.8 millimoles or 70 mg per deciliter. I'm more likely to get to goal with 2 or 3 drug combinations. And the key treatments, really, combination therapy with statins and PCSK9 lowering therapies, because you're making more LDL receptors and you're keeping them alive longer. Now, is there any rationale for early screening? Well, yes, there is. This is Dutch data, the Lurik paper from a few years ago. They followed up parents and children with familial hypercholesterolemia. The parents were identified because they had a myocardial infarction or coronary disease. So they're the index case. So even when you start statins, you're starting people with disease, medication. So many more of those will have recurrent events. But the children are event-free, and they're being started on treatment before the age of 20. So if you look, for example, at patients with FH and their unaffected siblings, there's 150 milligrams per deciliter difference in LDL cholesterol. As children grow up, naturally diet and other factors kick in, and their LDL cholesterol will go up from 98 to 121. But in the people with FH, we've brought LDL down from 230 to 160, and you can say that's not ideal. But what we've done is we've reduced their LDL by about 70 to 80 milligrams per deciliter, and we've importantly maintained it for a long period of time. So what that does is it reduces the likelihood of carotid intermediate thickness, for example. The people that were non-FH patients, of course, there's going to be some progression, but the difference is actually not as marked as you might imagine because you've started treatment early. And what that translates into in children with FH is basically we don't see much in the way of cardiovascular disease simply because of the fact that we've started treatment earlier. This is some work that we have in review, looking at people in general practice where they had a diagnosis of FH, they may have been unlikely to have FH, or the LDL is high and they could be potentially FH, but no one's made that diagnosis. Now, the important thing is that people with a diagnosis of FH will have recurrent events. But in terms of their survival, an early diagnosis means that their survival looks very similar to non-FH cases. Why? Because they're getting treatment, they're behaving with their lifestyle. In contrast, people who could have FH, but nobody's started to talk to them about it, they're carrying on with the same behavior, non-adherence to medication, all of those usual things. They lose 18 years of life. So really, this is conclusive evidence that we've got to start screening and identifying FH very early on in life. Now, we don't have many trial data and body count studies in FH. It's unethical. So what's the best data that we have? Well, we can go back and we can look at studies like WASCOPS, where there were a few people who had LDL above 190. So they had an FH type phenotype. Some of these people had other forms of vascular disease, and we excluded those individuals. And you can see this. There's 1,000 people had strokes or TIAs and so forth. That left 5,500 from 6,500. Just under 3,000 LDLs were less than 190, and then we had 2,500 with LDLs above 190. So let's call that primary severe hypercholesterolemia. This is the trial data of statins showing benefit, and on the right, placebo would be showing benefit. And what you basically see is that both the lower and the higher LDL groups benefit similarly, even with a modest reduction with pravastatin at a dose of 40 milligrams. This is coronary disease, this is major atherosclerosis events, 27, 25% relative risk reduction over 5 years. Now, in WASCOPS, there was a 15-year open label extension. So we can test the effect of further and earlier LDL lowering for longer and see what the effect is. Now, if those randomized patients continue onto their treatment, and even if placebo are offered medication, what you basically can see is that those people that you start treatment on early, when you add another 15 years of exposure to beneficial treatments, now you start to see mortality benefits, 28% reduction in CHD death. You now see 25% reduction in CV death, and you now see 18% reduction in all-cause mortality. So this piece of data was heralded in both the European guidelines and in the ACCHA guidelines as closing the remaining evidence gap. And this has really changed the level of recommendation. So if you see a patient with an LDL above 190, yes, of course, investigate them for FH, but you should offer them treatment irrespective of whether you're going to add in lifestyle or not. That means drugs. Now, is it possible that those people with more advanced disease do better with statin or cholesterol-lowering therapy? Well, to investigate that, we did exactly the same type of analysis in the 4S trial. So a randomized trial of statins versus placebo. The whole population had coronary artery disease, but we broke the population down into those with LDLs above and below 4.9. And then we could separate the coronary disease patient population down into 4 groups. So the numbers get smaller as you do this. So what were we looking at? Well, everybody's got coronary disease, and we've got 2,000 patients with an LDL above 4.9. Some, that coronary disease was late, and there's no family history. So that's one group. Then there's a group with a family history, but their own disease is not premature. And then there are some people with premature disease, but no family history. And there's a small number with premature coronary disease themselves and with a positive family history. And remember, they've got an LDL above 4.9. So they've got three things that by Dutch Lipid Network criteria would suggest that they are likely to be an FH patient. These are the relative benefits for all-cause death, cardiovascular death, coronary disease death, and major coronary events, just by LDL levels above and below 4.9. So the people with higher LDL levels seem to get slightly more benefits in relative terms, and that may be related to the fact that, as you know, if your LDL level is higher, the absolute benefit, or the relative benefit rather, depends upon the absolute reduction in LDL. So if you start with a higher LDL, you'll get a bigger absolute reduction in LDL, and therefore you might expect slightly greater benefits. And that's what's suggested here using CTT. But if you now break patients down by FH phenotype, so here we have non-FH, then we have LDL above 4.9 only, above 4.9 with a family history only, above 4.9 and premature disease only, or what we call the FH phenotype. Now, for the same, because these are people getting the same amount of LDL reduction, but there's a group of people with the FH phenotype getting really quite marked 80% or so reductions in all-cause mortality and also in major coronary events. So that's telling you perhaps that if we identified the right patients, their main driver or vulnerability to LDL, if you change that course, you might have a bigger treatment effect. And these are absolute benefits. So the group of patients with the FH phenotype get much bigger absolute reductions in clinical events. So that's just statins alone. Can we do better? Well, in the future, we will not be relying on monotherapy. We'll be looking at combination therapies. Statins, as you know, help us make more LDL receptors, but these are destroyed by PCSK9 lowering, by PCSK9. So targeting PCSK9 lowering therapies with the monoclonal antibody or reducing synthesis of PCSK9 in the liver to an siRNA-based approach can give you essentially about an 80% or so reduction in LDL with combination therapy, because each one gives you about 50%. You start with 50%, an additional 50% is a total of about 75 to 80% lowering of LDL. And in this meta-analysis comparing different PCSK9 lowering therapies, what we were able to show is that irrespective of genotype, siRNAs and monoclonals had very similar effects on LDL reduction. Now, if they have similar effects, if PCSK9 lowering, irrespective of how you do it, has a similar effect on LDL lowering, we can combine the data and ask a second question. Does PCSK9 lowering depend upon genotype? And the answer is no, it doesn't, because all of the genotypes behave similarly within the limits of the numbers that we had. So this means that you can choose different treatments that suit availability, cost, patient preference. So starting with screening and finding people earlier. Remember, we've only found 5% of the global population. We need to start them on statins and certainly ezetimibe, but we will be able to add in PCSK9 lowering therapies, whichever one you want, that you can afford, that the patient chooses, but we can get significant reductions in LDL and we can normalize their exposure and risk. So in conclusion, this compelling data that identifying elevated LDL cholesterol early in life in cases of FH can have health benefits. Late diagnosis is associated with worse outcomes. Late diagnosis is also associated with cardiovascular risk factors and comorbidities. So it's not rocket science. We need to find FH before the age of 20, because then we can normalize everything. You're going to need combination therapy. And you have to start thinking about combination therapy at the outset. So when you see these patients, if available, start with at least statins and ezetimibe and look to add in a PCSK9 lowering therapy early. So you just need to go on and do it, is the take-home message. Thank you for listening.
Thank you, Prof, for your quick and very meticulous update in the approach for heterozygous FH. We're going to move on. Al-Wali, Dr. Khalid Al-Wali is known in the region for his specialization in the lipidology. He's a senior consultant, a medical biochemist and lipidologist, head of clinical biochemistry department in lipid unit, Sultan Qaboos University Hospital. And also he's vice president of Oman Society for Lipids and Atherosclerosis. They have a long history in the training and studying basics in biochemistry and lipidology. They started from Oman in his basic medical degree, then in Miguel University, where he worked between 2004 and 2009. He worked with Professor Jacobs Jensis, one of the biggest lipidologists in the world. He's get his degree in biochemistry and lipidology from Canada, and then he moved on to have the lipidologist board from United States. So Dr. Khalid, he's one of the best people to talk to us about hypertriglyceridemia, which is one of the very common problems in our area. Dr. Khalid.
Good evening, everybody. Thank you very much for the kind introduction, and I would like really to thank the organizing committee for the kind invitation. It's really an honor, and it's my pleasure to be part of this event. My talk today will be about the hypertriglyceridemia, its association with the atherosclerotic cardiovascular disease, and I will talk about the new approaches in management and treatment of hypertriglyceridemia. These are my disclosures. So when we talk about atherosclerotic cardiovascular disease, it is very well known that reducing the LDL cholesterol by statins would significantly reduce the cardiovascular risk. However, it has been seen in many trials that even in patients treated with statin, there is still a substantial residual risk remains. In many studies has been also seen that even with a high dose statin, in one of the meta-analysis of many randomized controlled trials of statin, it revealed that the risk of major cardiovascular disease are still unaddressed. And also when we talk about the triglyceride and the non-HDL cholesterol, it has been seen in many trials that sometimes we can reach the LDL cholesterol goal, but we don't reach the non-HDL cholesterol. And in this meta-analysis that examined 8 trials of statins, they have seen that in patients reaching the LDL cholesterol, there is still with those a high proportion of patients, they don't reach the non-HDL cholesterol. And those who do not reach the non-HDL cholesterol, there is a very high significant cardiovascular risk. And in this meta-analysis, if you see from the graph, the last 2 rows, you see those patients with LDL target less than 100 milligram per deciliter, but still they have a higher non-HDL cholesterol. They have a high risk 1.32 compared to the reference population, those who have lower than 130 milligram per deciliter. So they have seen that among the statin-treated patients, the on-treatment levels of LDL cholesterol, non-HDL cholesterol, and ApoB were each associated with a risk of future cardiovascular events. However, they found that the strength of this association was greater for non-HDL than for LDL cholesterol and ApoB. And then in another study where they have assessed the proportion of individuals with diabetes and cardiovascular disease to see those who would attain the non-HDL cholesterol target less than 2.6, they have found that non-HDL cholesterol goal attainment is really less in people with diabetes and cardiovascular disease. And this is attributed due to the high triglyceride and high triglyceride-rich lipoproteins, which carries a remnant cholesterol. Then the question for many years, are triglycerides associated with cardiovascular disease? And if it is really associated, is it independent or really dependent risk factor? And is it only an association, or is it really a causality and a causal factor? And then I've shown you earlier that in patients with diabetes and cardiovascular disease, the higher the triglyceride, the higher the risk. However, in this meta-analysis of 61 studies, the median follow-up was 12 years, and they have excluded the studies in patients with cancer, diabetes, cardiovascular disease. And again, they have found that the higher the triglyceride level, the higher the cardiovascular disease mortality, and also the all-cause mortality. And if we look into more details, what is triglyceride and what is triglyceride-rich lipoprotein? So these triglycerides are carried by what is called triglyceride-rich lipoproteins, the VLDL, VLDL remnants, and chylomicron remnants. And they also carries not only the triglyceride, they carries what is called remnant cholesterol, or triglyceride-rich lipoprotein cholesterol. And if you see from this graph, the higher the triglyceride level, the higher the remnant cholesterol. And how can we measure the remnant cholesterol? So we take the total cholesterol, we subtract from it the HDL, that would be the non-HDL cholesterol, and then we subtract further the LDL cholesterol, and that will give us the remnant cholesterol, or what we call the triglyceride-rich lipoprotein cholesterol. And we have evidence from Copenhagen Heart Study that remnant cholesterol is strongly associated with the risk of myocardial infarction, the same way as with the LDL cholesterol, if not even more than the LDL cholesterol. But surprisingly, from that study, from the Copenhagen Heart Study, which examined almost 83,000 individuals, they found also that the remnant cholesterol is also strongly associated with all-cause mortality, more than the LDL cholesterol, as you can see from this graph. Another study was published last year where they have looked for triglyceride-rich lipoprotein cholesterol, small dense lipoprotein cholesterol, and incident cardiovascular disease. And if you see from the graph, they found that triglyceride-rich lipoprotein cholesterol, the same as for small dense LDL cholesterol associated with myocardial infarction and cardiovascular events. However, they found that the triglyceride-rich cholesterol associated strongly with even peripheral artery disease more than the small dense lipoprotein cholesterol. So these remnant cholesterol, triglyceride-rich lipoprotein cholesterol associated with cardiovascular disease, associated with cardiovascular disease mortality, all-cause mortality, and peripheral artery disease events. For many years, the focus was on LDL, and after the LDL trials, they started to concentrate on HDL, and they were trying to see, will the increment in HDL cholesterol would result in a reduction of cardiovascular events? Unfortunately, from these many trials, they were all negative trials, and we failed really to see that increment in HDL cholesterol by pharmacological agents would result in a decrease in cardiovascular events. And then the question raised in 2015 by Peter Levy, should we swap the CSO, the triglyceride on the CSO, because, should we really now concentrate more in triglyceride-rich lipoprotein more than HDL, and should we focus on triglyceride-rich lipoprotein cholesterol as a treatment target for cardiovascular risk reduction? It was also seen very clearly from the article published by Chapman and colleagues that triglyceride, HDL, and non-HDL cholesterol are associated with cardiovascular disease. However, when the triglyceride was further adjusted for several risk factors for HDL and non-HDL, you would see the attenuation on the risk for cardiovascular disease. And now the questions raised by many researchers, if you really adjust a triglyceride for non-HDL, are we adjusting the risk factor for itself? And that's why we would see the attenuation of the risk estimate. Because you can see if you adjust for non-HDL, and non-HDL would capture really the LDL, and also it captured the triglyceride-rich lipoprotein cholesterol. So if we adjust the triglyceride for non-HDL, maybe we are really adjusting the risk factor for itself, and that's why we will see attenuation of the risk. Now, also we have seen from many recent genetic studies that support causality of triglyceride-rich lipoproteins in cardiovascular disease. And if you see that many they studied the lipoprotein lipase, mutations in lipoprotein lipase, mutation on those what we call them the inhibitors and activators of lipoprotein lipase. And on those studies, they have found that if you really suppress the lipoprotein lipase activity by a mutation in lipoprotein lipase or one of its inhibitor or activator, that would result in a higher triglyceride-rich lipoprotein. And those genetic study, they found that it is really associated with cardiovascular disease. So if we look into the lipoprotein lipase, it is really the one that's responsible to digest and to remove the triglyceride from triglyceride-rich lipoprotein and transfer it into IDL and LDL, those to be catabolized and internalized by the liver. However, we have inhibitors and activators of this lipoprotein lipase, and any mutation that is a gain of function mutation of those inhibitors on the right side, that would result in a lower activity of lipoprotein lipase, and that would result in a high triglyceride-rich lipoprotein and a high risk. On the other hand, on the left side, apolipoprotein 5 is an activator of lipoprotein lipase, and any gain of function mutation that would result in a higher activity of lipoprotein lipase and a lower level of triglyceride-rich lipoprotein and a lower cardiovascular risk. In this study, actually, it was, very clear that in those genetic study, if you see number B, the remnant cholesterol, so those genetic mutation that would lead to an increase by 1 millimole of this remnant cholesterol, then that would result in a higher risk of cardiovascular disease. And in another interesting publication in 2019 by Brian Ferrance, they showed clearly that there is an association of triglyceride lowering LDL variants and LDL cholesterol lowering LDL receptor variants with the risk of coronary heart disease. And they have shown clearly that those variants with a higher activity of LDL receptor or with a higher activity of lipoprotein lipase would result in a lower risk for cardiovascular disease. But more interestingly, what they found that a reduction in the number of particles by measuring the ApoB, whether it was a triglyceride-rich lipoprotein particles or the LDL particles, if you reduce these particles by the same amount measured by the unit difference in ApoB, that would result in the same reduction of cardiovascular disease. And this study is also highlighting that the reduction of triglyceride-rich lipoprotein is really as important, if not more, than the LDL particles. Another interesting finding from the Copenhagen Heart Study, where they found that triglyceride-rich lipoproteins promotes inflammation much more than does the LDL particles. They measured the C-reactive protein, and they found that the C-reactive protein higher with a higher level of triglyceride. The same for LDL, it's high with LDL, but if you see the graph for the LDL particles, it really plateaus at certain level. So triglyceride-rich lipoprotein particles, they promote inflammation much more than does the LDL cholesterol. Another interesting study on the same area was published this year in the triglyceride and residual atherosclerotic risk, where they have found that in individuals with low to moderate cardiovascular risk, that hypertriglyceridemia associate with subclinical atherosclerosis and vascular inflammation, even in participants with normal LDL cholesterol. And this was the BISA study. That's the progression of early subclinical atherosclerosis. So they studied 3,754 individuals between the age 40 and 53 without prior cardiovascular disease, with low to intermediate cardiovascular risk. And they have found that the higher the triglyceride level, the higher the subclinical atherosclerosis. So what they have done, they have measured the index of inflammation by the fluorodeoxyglucose, the FDG, in multiple arterial zone. And what they found on those people with high triglyceride level, they have high inflammation index. So we have from this study, from BISA study, and from the Copenhagen study, now we have evidence that triglyceride-rich lipoproteins also promotes inflammation. And the higher the triglyceride, the higher the earlier subclinical atherosclerosis and inflammation. And now it's really very clear, it is not only the LDL particles, but also the triglyceride-rich lipoprotein particles that promotes the formation of foam cells and increase the level of inflammation at the arterial side, and through the leukocyte recruitment and increasing the inflammatory markers. Now, when we talk about the treatment of hypertriglyceridemia, for many years we have now the most three important treatment for triglyceride, whether it was mixed dyslipidemia or isolated hypertriglyceridemia. So we have the statins, omega-3, and fibrates. These are the three most commonly used. Sometimes also niacins can be used. So statins, yes, they are used to reduce the LDL cholesterol, but also they can reduce the triglyceride by 10 to 40%, and this is by reduction of the cholesterol and the triglyceride-rich lipoprotein particles. However, omega-3 and fibrates are more stronger in terms of triglyceride reduction, and they can reduce the triglyceride by 20 to 40 and sometimes 50% reduction. Now, the most important question, this reduction of triglyceride, will it be translated into a reduction of cardiovascular events? For LDL cholesterol, if you reduce LDL cholesterol in statin trials, in ezetimibe, PCSK9 inhibitors, yes, that will be translated in a reduction in cardiovascular events. What about triglyceride? So if you see the fibrate study, many fibrate study has been done, and when you look at the entire cohort, then you will not see any significant or statistically significant relative risk reduction. However, in some subgroup analysis and pre-specified also group analysis in the field and ACCORD trial, they have found if you concentrate in population with high triglyceride and low HDL, then there is a statistically significant relative risk reduction in cardiovascular disease. And now fibrates are also really used after statin for treatment of hypertriglyceridemia. Yes, there are some side effects and some interactions with the statins. And now we have another new, more selective B-bar alpha modulator, that is the bimafibrate. It's very efficient in reducing the triglyceride, and it has really lower side effects, lower interactions with the statins. However, till now we don't have a study to tell us, is this reduction in triglyceride and non-HDL by bimafibrate will be translated into a reduction of cardiovascular events. So we are waiting for the prominent study, and we are expecting that the results would be ready by mid of next year, 2022. And we hope that it will be a positive trial and that we would see a reduction in cardiovascular events. And for bimafibrate, the type of population they are studying is really patient with diabetics and with diabetic dyslipidemia. So this is really the target group that we think they would benefit more from bimafibrate. What about omega-3? So many studies has been done on omega-3 previously with a lower dose, but the recent two studies, they used a high dose of omega-3. They used 4 grams per day, strength trial, they used a combination of EBA and DHA, and reduced, they used only EBA. The strength trial, unfortunately, it really failed to show a positive results in terms of cardiovascular events reduction, and it was terminated. However, in reduced trial, they used only EBA, and it was really a positive trial, and they found that there is a reduction in triglyceride and increment of HDL, reduction in non-HDL cholesterol, and that was translated in almost 25% relative risk reduction in cardiovascular events. So it was really a positive study. Now I'll talk about the treatment, or the highlight of treatment of triglyceride. I will not actually talk in details about the guidelines, because I know the next talk will be about the guidelines, but I would really highlight the triglyceride treatment in the recent guidelines. So if you see in 2019, the European Society of Cardiology and the European Atherosclerotic Society guidelines, they now introduced a new risk category. They call it very high risk category. And then the level, the target for LDL was 1.4 millimole per liter. And in their guidelines, they highlighted the importance for non-HDL ApoB and triglyceride. For non-HDL cholesterol, they also mentioned that it should be a secondary goal. And then they have set the target to be 0.8 millimole per liter or 30 milligram per deciliter above the target for LDL cholesterol. They also highlighted the importance of ApoB as a secondary goal if it can be measured in your institution. For triglyceride, they highlighted the importance of triglyceride, but they did not specify a treatment goal. But they mentioned the level of 1.7 to indicate a lower risk, and if it is more than 1.7, then it indicates a high risk, and we need to look for other risk factors. They also have written a clear recommendation for drug treatment for patients with hypertriglyceridemia, and they have stressed the point that in patients with high cardiovascular risk, you should start with the statin, optimize the statin, and then if triglyceride high, then you can start the purified or the EBA, that's the IBE, omega-3, 2 grams twice a day, that's total of 4 grams. But also they mentioned for primary prevention that fenofibrate or bezafibrate that can also be considered in combination with the statin in those primary patients who meet the LDL cholesterol goal but still have high triglyceride level above 2.3. The American Heart Association 2019 also, they have concluded that prescription of omega-3 at a dose of 4 grams per day are an effective and safe option for reducing the triglyceride as monotherapy or as an adjunct to other lipid-lowering agents. Another excellent and very well-written guidelines that was published last year, where they talked more in detail about the triglyceride. It was the American Association of Clinical Endocrinologists and the American College of Endocrinology. And their algorithm, now we started to see that they put the 4 targets really together. And this is the first time we see that the targets not only for LDL and non-HDL and ApoB, but also for triglycerides. So if you see, there is now a target in their guidelines for the triglyceride. The same as for European Society of Cardiology and European Atherosclerotic Society, they put the target for non-HDL to be 30 milligram per deciliter above the target for LDL, and for ApoB the same. But now in these guidelines, they've mentioned that the triglyceride target should be really less than 150 milligram per deciliter. And in their algorithm, they highlighted actually also the role of IBE, and they stated clearly that on those patients with hypertriglyceridemia, if they have a cardiovascular disease or diabetes mellitus, you should start with statin, optimize and intensify the statin, and then if triglyceride is still high, then you give IBE 2 grams twice a day. That's a total of 4 grams. And for severe hypertriglyceridemia, also they highlighted the importance of starting diet, statins, and fibrate from the beginning, and also to combine with omega-3 if these are not successful to bring the LDL to bring the target within the recommended level. Again, another a new update this year. It was from the American College of Cardiology, and then their consensus decision pathway on the management of atherosclerotic cardiovascular disease risk reduction in patients with persistent hypertriglyceridemia. For patients with persistent fasting hypertriglyceridemia, they categorize the patient into 4 categories. Category number 1, those with atherosclerotic cardiovascular disease. So this is for secondary prevention. And category 2, those with diabetes but without cardiovascular disease. Category 2, those adults without cardiovascular disease and without diabetes. And the 3 category with triglyceride more than 50 but less than 500. And then the 4th category for severely elevated triglyceride and risk of acute pancreatitis. And again, the same for European guidelines and for the American Association of Clinical Endocrinology. They highlighted also the importance of ruling out secondary causes, optimizing diet and lifestyle, and bringing the LDL cholesterol within the target. And then if the triglyceride is still high, then also they recommend the same as the other guidelines to start with and to consider the IBE. The same also for the diabetes mellitus, to start with the IBE. But for those patients with a severely elevated hypertriglyceridemia, then you start from the beginning, the diet, statin, fibrates, and also combination with omega-3 if really needed. So to conclude my talk, now we really see that there is now the evidence are accumulating that triglycerides and triglyceride-rich lipoproteins are causally involved in the pathogenesis of atherosclerotic cardiovascular disease, and conditions associated with high triglyceride level have high atherogenic risk. And this is related to the fact they also have a high concentration of atherogenic cholesterol, that's the remnant cholesterol, and also high ApoB particles. Now, we highly recommend that non-HDL cholesterol, ApoB, and triglyceride should be really considered as a treatment goals for those patients with persistently elevated triglyceride. And we have seen that fibrates and fish oils appears really to have cardiovascular benefits in patients with high triglyceride and low HDL. However, we believe really the ongoing trials will better define the optimal therapy beyond statin for patients with high triglyceride and low HDL cholesterol. That's the end of my talk, and thank you very much for listening to my presentation.
Thank you, Dr. Khalid, for your quick summary and update on hypertriglyceridemia. We're going to move on to the next session. We're happy to have Dr. Nasreen Sayed from Bahrain. She's going to talk to us about update on recent dyslipidemia. Dr. Nasreen is very well known to us in the Gulf. She's consultant endocrinologist and lipidologist, Gulf Medical and Diabetes Center, president of the new Gulf Association of Clinical Endocrinology and Diabetes, and she had been graduated from the Arabian Gulf University College of Medicine. She had training in internal medicine in Sinai Grace Hospital, Wayne State University, Detroit, Michigan, in the United States, fellowship in training in endocrinology and diabetes in the Cleveland Clinic Foundation in Ohio. She had American board certified in clinical lipidology and fellow in American College of Physicians and fellow of the American College of Endocrinology. Dr. Nasreen will talk to us about the update and recent diabetes guidelines.
Thank you very much, Dr. Walid, for this kind introduction. Good evening, everyone. It's a pleasure to be with you. So I think I would like to thank the previous speakers, Professor Ray and Dr. Khalid Al-Waili, for their excellent talks. Some of the slides, for those of you who have attended Dr. Khalid Al-Waili's presentation, is going to be probably some of them repeated here. So this is going to be on update on recent dyslipidemia guidelines with great emphasis on the clinical implications. And these are my disclosures for the talk. So just an outline on what we're going to be talking about today. So first, we're going to start with the link of the LDL cholesterol and cardiovascular risk. I'm sure Professor Ray and Dr. Khaled covered that very well. A quick glance at the latest lipid guidelines, and then followed by a more sort of a depth look at the 2019 ESC guidelines, and finally, the clinical implications of the latest guidelines. So, you know, most of the studies, whether animal studies, lab investigations, genetic studies, or even RCTs, showed a clear link between LDL cholesterol as a risk factor for CHD. But like Dr. Khaled Al-Waili presented elegantly, non-HDL is equally important and is being the center of attention in most of the guidelines, of the recent guidelines. Non-HDL actually represent the cholesterol content of all ApoB-containing lipoproteins. So we're talking about the chylomicron, remnants, and the VLDL, IDL, and the large biunit LDL, including the LDL cholesterol particles. And the importance of the non-HDL is actually when you have triglyceride levels of 200 milligrams and above. And this is typically what we see in the region with metabolic dyslipidemia or diabetic dyslipidemia, where you have high triglyceride levels, low HDL, and normal or high LDL cholesterol level. We tend to neglect and calculate the non-HDL. It's a very simple calculation. You just need to subtract the HDL cholesterol from the total cholesterol, and you get the non-HDL cholesterol. That's very important to detect all these residual risks apart from the knowing your LDL cholesterol. Now, going back to the clinical trials that we have, we know that statins are the primary sort of lipid-lowering agent and the first-line lipid-lowering agents used in most of the clinical trials and endorsed by guidelines. And we know that there is a linear relationship with the lowering of LDL and reduced cardiovascular outcomes, mostly in statin trials. And this was seen in primary as well as secondary prevention trials. As you can see that the lower you achieve the LDL, the better you get the outcome. And some of these trials were actually not pure statin trials. They were in combination with ezetimibe, such as the IMPROVE trial. All of them showed that lower is the better, with better evidence of outcome. Now, looking at all these statin trials, whether primary or secondary prevention, you can see across these different statin trials that the benefit that you're achieving in terms of cardiovascular risk reduction, it ranges between 13% to 37%, meaning that there is still a 60 to 80% residual risk. So it seems that we're not doing a good job according to the previous trials. And the theory behind that, and with some evidence that we have, this could be that we are not tackling other residual risks like the non-HDL, the triglyceride, like Dr. Khaled showed us just shortly. And also maybe the LDL levels that we were achieving in these trials were not low enough for us. And that really brings us to the looking at how important it is to go with a very low LDL level, and is it safe? And if we look at the different Mendelian randomization studies or the prospective cohort studies, randomized controlled trials, all of them show that when you achieve really low levels of LDL cholesterol, it's not just the amount of the LDL cholesterol, it's also the magnitude of exposure to lower LDL cholesterol. You will have the lowest possibility or probability of cardiovascular event. And added to that, as presented in the 2019 European guidelines, they showed you that all these CTT meta-analysis of the statins, the IMPROVE trial, also the PCSK9 inhibitor trials, such as 4-year Odyssey, showing the evidence for the evolocumab and alirocumab, all of them showed that the lower we go with the LDL, the better is the cardiovascular outcome. And going below even 30 milligrams per deciliter was pretty much very safe in these trials. So looking at a quick glance at the guidelines and recommendations that we have the ACC-AHA. Now, ACC-AHA went through different sort of stages of modification of their guidelines since the release in 2013 and dividing the group of patients into 4 groups. There have been some adjustments to the guidelines, even the recent ones back in 2019 and 2020. Basically, they're sticking to the 4 groups, the clinical atherosclerotic cardiovascular disease. The second group is primarily FH patients. The third group, diabetic patients. And the fourth group are patients with high calculated risk, which is 7.5% and above. Now, very important that the ACC primarily focus on intensity of statin therapy and the LDL reduction, percent reduction, while as you can see the European guidelines and the National Lipid Association guidelines, they have sort of different sort of categorization of risk, ranging from very high to high, moderate and low risk. And these guidelines actually look at the target LDL cholesterol levels and absolute values. And you can see that the target sets for the LDL cholesterol is it's very stringent now according to the latest guidelines. For the very high risk is below 55 milligrams, and according to the NLA still at the below 70 milligrams. And all these trials look at statins as the first line therapy, and commonly, usually the second line agent to be added is ezetimibe. Showing the ACE guidelines, the American Association of Clinical Endocrinology guidelines, like Dr. Khalid just showed you, the categorization of the risk is a bit different. So they are looking at extreme risk, very high risk, high and moderate and low risk. So the extreme risk patients are those with progressive atherosclerotic cardiovascular disease, even after achieving LDL below 70, and those with established cardiovascular disease, but in patients with high risk, like, for example, diabetes, CKD, or FH. And also patients with history of premature atherosclerotic cardiovascular disease at young age, like below 55 in males and below 65 in females. Like Dr. Khalid presented elegantly, the targets set here is not just looking at LDL, but equally looking at the non-HDL, and the ApoB lipoproteins. Again, very strict targets here, below 55 for the LDL, below 80 for the non-HDL, for the extreme risk category. Now, looking at the ACC-AHA, going through the phases of modification, there is a great emphasis and more detailed sort of elaboration in the recent updated guidelines. So in addition to their well-known category of the clinical evidence of atherosclerotic cardiovascular disease, they emphasize on another category, which is a very high-risk atherosclerotic cardiovascular disease. And these are patients who come with multiple major events, or one major cardiovascular event, or who have multiple risk conditions. So what are these multiple risk conditions? Age above 65, FH patients, prior CABG or PCI, diabetes is considered among these risks, hypertension, CKD, current smoking, and persistent high LDL despite lipid-lowering therapy, and finally, history of congestive heart failure. For these patients, they have set a threshold of LDL 70. So if your patient is at LDL 70 or above, you need to be really aggressive and consider maximum tolerated statin in these patients, and very much consider non-statin therapy in these patients. So ACC was not previously looking at non-statin therapy in their initial 2013, but now there's a great emphasis on non-statin therapy, including ezetimibe and PCSK9 inhibitors. Now, looking at the other general guidelines, so one of them is the guidelines or the consensus clinical recommendation that we have published for the lipid guidelines in the Middle East pertaining to the Gulf region and Middle East. This was published back in 2015, and we are publishing another one coming soon, hopefully by end of this year. Again, very important for you to understand the guidelines or the recommendations pertaining to our region. So of course, we can invite you to look at all these guidelines and other guidelines at our website, the GAID.info clinical guidelines. You can see all the guidelines related to lipids or other guidelines, so you can have them for the review. But there is one upcoming updated guideline very soon, end of this year. So looking into more depth on into the 2019 European guideline that sort of form a platform for the updates that we are getting in other guidelines like the ACC and so on. So again, this is a popular slide that most of you have seen. We are categorizing the risks into very high risk, and these very high risk, remember, these are patients with established cardiovascular disease, FH patients with cardiovascular disease or other major risk factor, severe CKD, diabetes and target organ damage, or diabetes with more than 3 major risk factors, or early onset of type 1 diabetes. And remember, the risk score used in the European guidelines was the score risk calculator. So more than 10% was considered very high risk. In these patients, the target LDL is now below 1.4 millimole or below 55. While the high-risk category is a score risk above 5% or below 10%, also markedly elevated single risk factors, or FH patient without major risk factor, or moderate CKD, so GFR between 30 to 59, diabetes without target organ damage, or diabetes duration more than 10 years with other additional risk factors. So these are high risk, and the target is below 1.8 or 70 milligrams per deciliter. While the moderate risk factor is a score between above 1% and below 5%, and young patients like type 1 diabetes below 35 years or type 2 diabetes below 50 years, or with a diabetes duration less than 10 years without other risk factors. For these patients, you need to achieve LDL target below 2.6 millimole or below 100 milligrams. And the low risk is, of course, LDL cholesterol below 3 millimoles per liter. In addition to that, a very important recommendation by the European guideline is that for patients with evidence of atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, the LDL goal should be as low as below 1 millimole or below 40 milligram per deciliter. So this was another addition very important to the guidelines. So how you should be going through the decision making in choosing your lipid lowering therapy, and most of the guidelines agree with that now, and giving a great consideration for combination therapy. So you need to know your baseline LDL to start with, and then you need to know which each class of lipid lowering in terms of percent reduction that you can achieve. So look at the moderate intensity statin that unfortunately most of us are using in the clinical practice. It just gives you 30% reduction, while the high intensity statin gives you 50% reduction. And when you have a combination of high intensity statin plus ezetimibe, you achieve 65% reduction. PCSK9 alone gives you 60%, but if you combine PCSK9 with moderate intensity statin, you achieve 75% reduction. And if you have the three of them together, you achieve 85% reduction from the baseline LDL. So that absolute LDL reduction that you achieve, and you reach to that relative risk reduction along with the baseline risk, you will reach to your absolute risk reduction in your patient. So the guideline recommends that you need to categorize your patient. The first thing you should tell yourself, is my patient in the very high risk or moderate or low risk category? And based on that, you would decide whether there is indication for drug therapy or not. And after that, if there is indication for drug therapy, of course, don't forget lifestyle intervention, very important. But the first line is high intensity statin or maximum tolerated statin based on your baseline LDL cholesterol. So, and if you achieve the LDL goal, that's great. If not, the guidelines recommend adding ezetimibe If you achieve your goal, that's great. If not, then the guidelines recommending adding PCSK9 inhibitor. Now, there is a great evidence for PCSK9 inhibitor in secondary prevention for very high-risk patients and also as primary prevention in FH patients. But the guidelines are telling you you can consider PCSK9 inhibitor in primary prevention in those without FH, like diabetes, CKD, and so on. And very important also, the guidelines emphasize you can consider PCSK9 inhibitor class if you have statin intolerance. So if you have statin intolerance after a re-challenge, you can consider ezetimibe. And if still not tolerated, you can consider PCSK9 inhibitor. And that was mentioned in the guidelines. What about type 1 diabetes? Statins are indicated in type 1 older than 30 years or have had diabetes for more than 10 to 20 years or have established nephropathy or have other CVD risk factors. Elevated triglyceride, I'm just going to go through this quickly because Dr. Khalid Al-Waili presented that. The cutoff, the threshold at which you should consider is the triglyceride 2.3 millimoles or above 200 milligrams. You should be considering medication. Omega-3, which is the icosapent ethyl at a dosage of 4 grams per day. So this is very important. We're talking about not over-the-counter omega-3. The study looked at specifically EPA that showed the positive cardiovascular outcome evidence. As Dr. Khalid Al-Waili showed, the primary endpoint, a reduced trial for the icosapent was 25% relative risk reduction, 58% were diabetic patients enrolled in trial, and 26% relative risk reduction in secondary endpoint when comparing icosapent ethyl to the placebo, and that's why it was indicated and recommended by the guidelines. The guidelines also give you a choice of using fenofibrate and bisafibrates in patients with high triglyceride, emphasizing the importance of these agents, especially in diabetic or metabolic dyslipidemia who have high triglyceride level, low HDL, and normal or high LDL cholesterol level. CKD patients or guidelines place them in the extreme, very high or high risk category. Statins are still the first choice in these patients. Combination with ezetimibe PCSK9 inhibitors can be used. And, the dose modification is very important in kidney patients. Just remember that atorvastatin does not require much dose modification. Fluvastatin, the same thing. Pravastatin, the same thing. Ezetimibe also does not require dose modification. For the triglyceride, gemfibrozil does not require dose modification. And omega-3 fatty acids, they don't require dose modification. Similarly, for PCSK9 inhibitor class. Now, very important to know the implications of the guidelines, the latest updated guidelines. And very interesting to present is the Davinci Study. Now, Davinci Study was a cross-sectional observational study of lipid-modifying therapy use in secondary and primary care. And the aim of the study was to present or show a contemporary information on the LDL goal attainment across different European countries. So this was over Europe only. Now, the study was conducted based on the 2016 guidelines of the European guidelines, and it was ended before the release of the 2019 guidelines. But what they did, they just published the post hoc analysis of the data that they have and applying the 2019 guidelines to see and compare with the 2016 guidelines. So again, the Davinci looked at the goals to comparing the 2016 with the 2019 guidelines. As you can see, no change in the low risk. The moderate risk, of course, you can see it was below 3, now it's below 2.6. For the high, very high, and second CVD event, of course, the 50% reduction was maintained, but the great emphasis, and it was previously or, but now it's and a target. As you can see, the high risk was changed from below 2.6 to below 1.8, and the very high risk from below 1.8 to below 1.4. There was no data available or recommendation available regarding the second CVD event, but now it's available and should be 50% reduction and below 1 target. So when we compare the percentage of patients who attained the LDL goal in the Davinci study, comparing the 2016 in dark orange bars versus the 2019 light orange bars, you can see that a lower percentage of patients at different classes of lipid-lowering classes were able to achieve the 2019 guidelines. It was difficult to do that. And when we look at this slide again, the proportion of patients achieving the goal, comparing the 2016 with the 2019 guidelines, the 2019 is like the shaded bars. You can see again, less patients were able to achieve the targets when we apply the 2019 guidelines compared to 2016. And when we look at the proportion of patients receiving lipid-lowering therapy, so let's take, for example, the moderate risk category. 60% of patients were receiving moderate intensity statins, so the orange is moderate intensity, and 16.9% receiving the high intensity statin, 9.8% only receiving ezetimibe, and 1.6% only receiving PCSK9 inhibitor. And look at the shocking result for the high risk. High risk, 63% receiving moderate intensity statin, only 18.9% receiving high intensity statin, 4% receiving ezetimibe, 0.5% receiving PCSK9. And the most shocking is the very high risk category. You have only 36% receiving the high intensity statin, 9% only receiving ezetimibe, and 1.2% receiving only the PCSK9 inhibitor. That's a very fresh data from the Davinci. Also, looking at the mean LDL cholesterol in patients with stabilized lipid-lowering therapy. In primary prevention, we could accept that. The mean was like about 2.5. But look at the established secondary prevention across the different sort of secondary prevention. Look at the LDL. The mean LDL achieved in these patients on lipid-lowering therapy was around 2 millimole, or even a little bit higher than 2 millimole, showing that we are failing to achieve these guidelines and targets. So the conclusion of the Davinci study shows that among patients receiving lipid-lowering, fewer than half of the very high risk primary and secondary prevention patients achieved the 2016 goals, with approximately 1/5 only achieving the 2019 goals. Even with optimized statin usage, the prevalent gap between guideline recommended LDL goals and their implementation in clinical care will require greater utilization of non-statin in combination with statin for patients at highest risk. So what do we learn from the Davinci study? First, clinicians need to change their thinking with respect to how they manage high and very high risk patients in routine practice. Second, with even more stringent LDL goals introduced in 2019 guidelines, goal attainment is even lower, as we know. Failure to optimize the use of high-intensity statin therapy is one of the factors for failure to achieve the targets. It is, however, clear that 2019 guidelines for high and very high-risk patients is largely unattainable on high-intensity statin monotherapy. Such patients also require combination therapy. Now, a practical message from the Davinci is to assess risk. Just look at the risk. And if your LDL goal is below 1.8, consider early, and I highlighted early meaning that as soon as possible. Your first step when you decide on lipid-lowering therapy, consider using combination therapy with ezetimibe as suggested by 2019. However, keep in mind, the Davinci study also demonstrates that very high-risk patients, around 4 in 5, will likely require PCSK9 inhibitor combination therapy, potentially without the ezetimibe step. Now, this was the data, a fresh data, a post hoc analysis for the Davinci study applying the 2019 guidelines. What about our region? That was for the European countries. What about our region? It would be very interesting to see what's going on in the Gulf region. And to answer this, we have an ongoing, fascinating project, the Gulf Achievement of Cholesterol Targets in Outpatient Study, or the Gulf Action Study, Identify and Act project. That is a very fascinating study that has already started. The objective of the study is to up-to-date comprehensive assessment of the current situation of the dyslipidemia patterns and management in the Arabian Gulf region, develop a quality improvement initiative to enhance the achievement of the LDL targets in patients who did not achieve them based on the latest ACC or European guidelines, determine the perceptions and beliefs of the treating physicians as well as patients in the Gulf region regarding dyslipidemia. And for that, they're going to have a sub-study looking at physicians separately and the patient's perspectives separately. And finally, determine the presence of subclinical atherosclerosis in patients without evidence of cardiovascular disease by coronary calcium score, other imaging modalities, and blood levels of biomarkers and of inflammation. The results of the study is expected hopefully to be released by 2022. And I think that would add a very, very informative sort of information about the status of how we are implementing the guidelines in the region and compare it to what the European have found. So in summary, looking at all the guidelines and particularly the most updated from 2019 and on guidelines, we know that LDL goals were lowered for moderate to high cardiovascular risk patients. For patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, an LDL goal of less than 1 or less than 40 milligram may be considered. In high and very high risk categories, at least 50% reduction in LDL levels from baseline, a proxy for the use of high-intensity statin was added. The latest guidelines recognize the high and very high risk of certain primary prevention patient groups, including those with diabetes or familial hypercholesterolemia without established atherosclerotic cardiovascular disease or with chronic kidney disease. While statins are first-line treatment to lower LDL cholesterol, the guidelines also recommend combination with non-statin LDL lowering therapy to achieve the stringent new targets. And you might need to consider combination as early as possible in your high-risk and very high-risk patients. And with that, I would like to conclude, and thank you very much for your listening.
Thank you, Dr. Nasreen, for your elegant and clear and concise, and you have simplified actually the guidelines. Thank you very much. The last speaker for the lipid session is Dr. Lee Kaplan. He is well known to you. He already gave nice lectures in the past 2 days. He's just briefly, he's the director and founder of Obesity and Metabolism and Nutrition Institute at Mass General Hospital. He's associate professor of medicine at Harvard Medical School. He's the past president of Obesity Society. His research interest is in gut microbiota and regulation of energy balance and metabolism. His graduate both in medicine and his training all has been done at Harvard Medical School. He's also he has an important course in obesity. It's called the Blackburn course, which happens in June each year, and that's highly recommended course for people who's interested in obesity. So, Professor Kaplan, go ahead and start your lecture, and the floor is yours.
Good evening. I'm going to talk to you tonight about the disease called non-alcoholic fatty liver disease, or Nafld, and in particular about the pathogenesis and treatment of the more progressive form of this disorder called NASH, or non-alcoholic steatohepatitis. Now, non-alcoholic fatty liver disease is the most common disease worldwide, and it's especially prevalent in advancing or modern societies, but it really is present in parallel with obesity and diabetes in virtually every country in the world. It's characterized by hepatic fat deposition and is frequently progressive, leading to inflammation, liver cell damage, fibrosis, and over several decades to cirrhosis in some of the patients. It's not related to alcohol consumption, so it has to be distinguished completely, although some of the histology looks similar. Now, the prevalence of Nafld and NASH is shown in this map from the World Health Organization. And what you can see here is that in the Middle East, where you're all located, has one of the highest rates in the world. Nearly a third of patients, or of people actually in the Middle East, having Nafld in some form, either the mild form, just steatosis, or the more severe form. If you look at people with diabetes, you can see here that the prevalence of Nafld in diabetes is enormous, with 2/3 of people with diabetes in the Middle East having Nafld, and some of those, perhaps as many as 25%, having NASH. Now, what are the definitions? Well, hepatic steatosis is just excess fat deposition in the liver, and we sometimes call it bland steatosis because there's nothing more than fat. When non-alcoholic fatty liver disease is the full spectrum of diseases with fat in the liver, and NASH is non-alcoholic steatohepatitis, which is hepatic steatosis, fat in the liver with features of inflammation and fibrosis, and you need both to have the diagnosis of NASH. NASH is associated with progressive liver disease. So once you get NASH, you know that you're on the pathway toward progressive liver disease. As I'll show you in a minute, the people with bland steatosis alone, most commonly don't actually progress to NASH or further. But the number that do progress to NASH will then follow a pathway over several decades all the way on the way to cirrhosis. Now, Nafld and its complications are shown here. Here's a normal liver. If you have metabolic dysfunction, you can get isolated steatosis, or you can get NASH. If you get NASH, you'll see progressive fibrosis leading to cirrhosis. And it's a little bit debatable as to whether isolated steatosis can turn into NASH, or whether you develop steatosis or NASH at the moment that the fat starts to collect in the liver. There's probably a little more evidence that you either go down one pathway, the one on the top, or the pathway on the bottom, rather than interconverting between these two pathways. Now, in addition to the progression towards cirrhosis and liver failure, one of the other complications of Nafld is hepatocellular carcinoma, and the other is cardiovascular disease. We don't yet know whether the cardiovascular disease comes from the liver disease, although there's some evidence that liver disease can contribute directly to cardiovascular disease, or whether the cardiovascular disease is just a component of so-called metabolic syndrome or metabolic dysfunction that occurs in the presence of fatty liver disease, because fatty liver disease occurs in people with metabolic dysfunction. Now, there's a histological scoring system that allows us to assess the severity of Nafld. And there are two separate scores. The first one is the Nafld Activity Score, or NAS, and it's a 0 to 8 score. Steatosis can give you anywhere from 0, if you have no steatosis, up to 3. Lobular inflammation is on a scale from 0 to 3. And hepatocyte ballooning, or cell injury, is on a scale from 0 to 2. And you just simply add up those 3 subscales to get the total, which can be as high as 8. There's a fibrosis staging that goes from F0, meaning no fibrosis, all the way to F4, which is cirrhosis, and I'll show you in the next slide how that goes. So the fibrosis stage is dependent upon where in the lobule of the liver you'll see the fibrosis. So, of course, the liver is fed by vessels on the edge of this lobule here in the portal zone. You can see that the portal, the ramifications of the portal vein shown here in blue on the edge of this diagram, and the hepatic artery shown in red on the edge of this diagram, feed into the liver, and then the blood flows across the lobule and drains through the central vein shown in blue in the middle of this diagram. The central lobular or perisinusoidal region of the liver is zone 3. Portal is zone 2, and in between is portal is zone 1, and in between is zone 2. So in fibrosis stage 0, there's no fibrosis, only fat in the liver. In fibrosis stage 1, there's perisinusoidal, or zone 3 fibrosis, or there's a small amount of zone 1 or periportal fibrosis, but not fibrosis in both places. In F2, there's fibrosis in both places, both perisinusoidal and periportal, zones 1 and zone 3. For F3, you see bridging fibrosis, where it goes from the perisinusoidal region to the periportal region through zone 2, and that's called bridging fibrosis, and that will be called F3. And finally, F4 is cirrhosis, where you have a much more severe form of fibrosis that actually chokes off some of the functional hepatocytes so that the liver begins to have liver failure on top of the severe fibrosis. Now, the clinical implications of Nafld and NASH are that it's undiagnosed in most cases, even though it's highly prevalent, particularly in patients with type 2 diabetes. And only about 40% of people with any degree of severity of Nafld have elevated transaminases. So whether you have just bland steatosis or you have cirrhosis or anything in between, a minority of people have elevated liver enzymes. So that's not a very sensitive test for looking for it. But the epidemiology is sensitive, as I've already indicated, particularly severe obesity or type 2 diabetes. Now, it can progress to cirrhosis and liver failure, as we've already talked about, and it's already the second most common cause of liver transplantation in the United States and in Europe, and is continuing to grow, and so is likely to become the most common cause of liver transplantation in most parts of the world where transplantation is routinely done within the next half decade. It's associated with hepatocellular carcinoma, which is one of the most common, if not the most common, solid organ cancer in the world. And it's associated with up to double the risk of developing cardiovascular disease, which is the major cause of death of people with NASH. So although people with NASH do die of liver failure or hepatocellular carcinoma, far more common is dying in an accelerated way from cardiovascular disease. Damage to the liver from Nafld is often synergistic with other forms of liver injury. So if you have Nafld and then you get viral hepatitis or you get autoimmune hepatitis, or if you use alcohol or drugs that cause liver injury, those causes of liver disease are likely to be worse if you have underlying fatty liver disease. So as I indicated, advanced fibrosis is associated with increased all-cause mortality and increased cardiovascular mortality. And if you look at the advanced fibrosis, which is stage F3 or F4 fibrosis, you can see there that in this Kaplan-Meier curve that there's a drop-off in life in advanced fibrosis, specifically from cardiovascular disease. Now, you can see that here. If you look at all-cause mortality, advanced fibrosis is associated with more than threefold increased all-cause mortality. And as you can see here, that most of that or much of that increased mortality is from cardiovascular disease. Now, the severity of liver fibrosis staging predicts mortality. So if you look at all-cause mortality, there's a linear relationship between increased stage as you go from F1 to F4 and all-cause mortality. If you look at liver-related mortality, you see that there's a big bump in mortality between fibrosis stage 3 and 4. There's still an elevation in fibrosis stage 2 and 3, but it really goes up substantially in stage 4. So what that tells you is that the substantial increase in cardiovascular mortality is particularly notable in fibrosis stages 2 and 3, where it is by far the majority of the total mortality, as compared to stage 4, where liver mortality also plays an important role. Now, in terms of clinical screening and diagnostic strategies, remember to consider liver disease in every patient you see with obesity and type 2 diabetes. The severity of that liver disease is going to vary from patient to patient. And we'll go through an algorithm which is just in press now from the American Gastroenterological Association. And this algorithm was developed by a consensus group representing multiple specialties in the United States, and we'll come back to that in just a moment. Liver enzymes can be used to aid routine screening, but they're not the be-all and end-all because they're not sensitive enough. to find fatty liver disease in an unselected population. The risk scores, and I'm going to talk about one of them called FIB4, are predictors of fibrosis, but they're not measurements of fibrosis. So measurements of fibrosis have to be done in different ways. And ultrasonography is a sensitive tool to assess steatosis, but it's not at all useful for staging or assessing progression to NASH or beyond NASH. Elastography, and one of the forms of that is made by a company called FibroScan, is a very sensitive and specific tool to assess the degree of liver fibrosis by measuring the stiffness of the liver. As the liver develops fibrosis, it becomes stiffer, and you can use this type of test in order to assess the degree of fibrosis without needing to do a biopsy. And unfortunately, there's no good non-invasive tool to assess inflammation or cell injury. So that has to be done by biopsy if we're going to be assessing it. And right now, most clinical trials use a biopsy as part of the evaluation so that we have a good sense of inflammation and hepatic injury. Now let's look at this algorithm, which is, as I mentioned, is in press from the American Gastroenterological Association. The first thing you want to do is you want to identify patients at risk. And so you have if you have two or more metabolic risk factors, components of the metabolic syndrome, or just diabetes alone, or steatosis on any imaging modality. So that could be by ultrasound, by CAT scan, by MRI. Those are patients that should be considered at risk. Step 2 is to do a history and the laboratory test, assess for alcohol use, do a CBC, do a comprehensive metabolic panel. And what you're basically looking for is to get to step 3, which is non-invasive testing for fibrosis. However, if there's an elevation of the liver test, of the transaminases, you want to take a side trip just to make sure that there are no other liver diseases that either are causing the liver injury or are coexisting with fatty liver disease and will influence the way you treat the patient. So step 2A in evaluating for other forms of liver disease is really straightforward. You can do this in collaboration with colleagues who are hepatologists, or you could do it yourself. Get a sense of how much alcohol the individual is drinking, do hepatitis C, antibody and RNA testing, consider serologic testing for hepatitis B if the patient's at higher than average risk for hepatitis B, and consider other serologic testing looking for autoimmune hepatitis and hemochromatosis, alpha-1 antitrypsin disease, and Wilson's disease, not listed here, in younger patients only. If the test results are consistent with the presence of other forms of liver disease, then treat the patient as though they have those other forms of liver disease. And if that means referring to a hepatologist, then this would be an indication to do that. Now, if they're negative for other forms of liver disease, they go back to the main algorithm that I talked about, and that's step 3, non-invasive testing for fibrosis. And so the first non-invasive testing for fibrosis is a serologic test or a group of tests called the FIB4. And FIB4 is a calculated value. You can go online and just do FIB4 calculator, and you'll get a FIB4 calculator. There are several of them on the web. And it's based on the patient's age, their AST level, their ALT level, and their platelet count. And if that level is low, less than 1.3 as shown here, the patient is low risk, and you don't need to do anything further except repeat the non-invasive testing in 2 or 3 years and start all over again. If the FIB4 level is high, over 2.67, then that's a high-risk patient and probably is progressing and therefore probably needs to be evaluated and perhaps treated in some degree by a hepatologist. In the middle, which is where you'll see a lot of your patients, between a FIB4 of 1.3 and 2.67, is somebody with indeterminate risk. And because the risk is indeterminate, we're not sure of what the risk is, we move to the second phase of testing, which is liver stiffness measurement, or FibroScan is the one that's most common. And so again, if the liver stiffness measurement is less than 8, it's low risk. You go back to the low risk and you just repeat all the studies in about 2 or 3 years. If it's high, above 12, then you should refer to a hepatologist because this person has progressive liver disease. And if again it's indeterminate, between a liver stiffness measurement of 8 and 12, you should consider referring to a hepatologist for liver biopsy to really assess. And this is the one group that makes it through 2 stages of indeterminate risk that needs to be referred specifically for a biopsy. Now, the current treatment of Nafld, once you assess that the patient has Nafld, comes in 2 strategies. The first is to treat the liver disease, but our opportunities for treating liver disease, this kind of liver disease, directly are very limited. We have vitamin E, which shows a histological benefit in NASH without type 2 diabetes, but doesn't show a benefit in those patients who had type 2 diabetes. And pioglitazone, which shows a histological benefit in NASH and may even be better in patients with type 2 diabetes because of the improvement in insulin sensitivity that is associated with the thiazolidine diones. Now, the other approach, which is more common today, is treat the underlying obesity, because if you get a patient to lose a substantial amount of weight, they are likely to improve their NASH. As I'll show you in the next slide, at least 7 to 10% durable long-term weight loss appears necessary to improve histology and liver tests. So weight loss is associated with remission of steatohepatitis. Here's a study of about 300 adults with Nafld. The average Nafld score, the NAS, was 4.8, which is sort of in the middle between 0 and 8. But 61% had F0 fibrosis, which means 61% had no fibrosis, which makes this a very mild form of Nafld as a group. So not only 39% of patients here had NASH in this whole population. Intervention was 52-week lifestyle-based therapy with a calorie reduction diet and extra exercise. And the average weight loss was 3.8% in this group. 30% of the patients in this group lost more than 5% of their weight, and the average reduction in NAS score was 1.58. And what you see here is if you look at the weight loss against the remission of steatohepatitis, the remission of NASH itself, back toward Nafld, you see that if the weight loss was over about 7 to 10%, you saw a substantial portion, over 2/3, achieving remission of their steatohepatitis. Now, the other way that it's been looked at, of course, is metabolic and bariatric surgery, and the 2 most common forms of surgery, as you well know, are gastric bypass and sleeve gastrectomy, which are both recommended for patients with a BMI over 35 and a major obesity complication, including NASH. That's one of the complications. The cutoff points for the recommendation for surgery are lower in East Asians and South Asians, as you may well be familiar with, but we'll use 35 for everybody else in the world. And one nice study has demonstrated that bariatric surgery improves several aspects of Nafld. And there are a number of other studies that do that, but not as well as this one does. And this is a small study, 65 patients with advanced NASH, either F3 or 4, or NAS score 3 or 4, meaning that they had to have at least moderate NAS, meaning moderate inflammation and fibrosis, but they had to have a fibrosis that was in the bridging fibrosis or cirrhosis category. And the intervention was gastric bypass or sleeve gastrectomy, and the average time to follow up was 6 years. So we're looking way down the line after they've had their surgery. The average weight loss at that point was 23%, and the average decrease in the NAS score was 3.12, or about twice as much as in the previous lifestyle-based study that I just mentioned to you. And what you see here is that at baseline, the Nafld activity score everybody was in the NAS 3 to 4 range, and nobody was in the steatosis or NAS 0 to 2 range. But after 6 years later, after they had the bariatric surgery, you can see here that 97% were in the steatosis NAS 0 to 2 range. So therefore, there was an improvement in the characterization of the NASH itself, independent of the fibrosis. Now, the predictors of improvement of high activity NASH were shorter diabetes duration and greater weight loss, not terribly surprising. If there was no severe fibrosis, meaning it was only F3, then about a third of those patients, up to a third of those patients, had a normal follow-up biopsy, meaning they had no fibrosis. So the fibrosis, even at starting at stage F3, went down to normal in about a third of the patients. Now, if you look at the fibrosis, you can see that everybody was either F3 or F4 at the beginning of the study on the left here. And you can see a substantial number became F0 or F1 after the surgery. Some of the patients, of course, about 45% remained at F3 or F4. 3% were at F2, and another 50% or so had come down to F0 or F1. So substantial improvement. And again, predictors of improvement in fibrosis included younger patients, improvement in type 2 diabetes, longer time until follow-up. So if the patients were further out from surgery, they did better because there seems to be progressive improvement in the fibrosis. And if they underwent gastric bypass, they did better than the ones who underwent sleeve gastrectomy. Now, the effect of bariatric surgery then on Nafl and NASH is that there's an immediate improvement in steatosis. There are effects on inflammation, necrosis, and fibrosis, but those are less clear. The study I just showed you was very clear, but there are a number of other studies that are less clear. Weight loss and other metabolic improvements after surgery definitely appear to provide hope of a benefit. And there are no large or well-controlled studies other than the smaller one that I just showed you. The first very well-controlled studies in a substantial population are ongoing at this point. The effects of surgery to prevent progression to cirrhosis or hepatocellular carcinoma, which really are the bad outcomes that we worry most about as far as the liver is concerned, it's not clear yet. There's no study that shows that those hard outcomes are in fact prevented by bariatric surgery, at least not yet. And finally, the mechanism of benefit, whether it's weight loss alone that's doing this or weight loss independent metabolic effects of the surgery, such as have been seen for diabetes, where in diabetes, you see the improvement in diabetes is partially due to weight loss and partially due to weight loss independent effects of the surgery. But that differentiation for fatty liver disease is not yet known. Now I want to turn to the first medication that I think has the promise of having a substantial benefit for patients with NASH, and that's semaglutide 2.4 milligrams. There were 320 participants in this study with stage 2 to 3 fibrosis, so nobody with stage 4 fibrosis or cirrhosis. It was a 72-week treatment period with either semaglutide or placebo. The primary outcome was NASH resolution without worsening of fibrosis, which is the outcome that the regulators are interested in. And what you see here is if you look at placebo, 17% of patients who received the placebo achieved the primary outcome. That seems pretty high, except you have to recognize that this is based on 2 sequential liver biopsies, one at the beginning and one at the end of the study. And there's a lot of heterogeneity across the liver in terms of the degree of fibrosis, the degree of inflammation, and cell injury at different parts of the liver. So some of that 17% is probably randomness. But if you look at the highest dose of semaglutide, 0.4 milligrams per day, which is the equivalent of 2.4 milligrams per week, you see that 60%, nearly 60% of patients achieved complete remission of their NASH without worsening of the fibrosis. So that's highly statistically significant, it's highly clinically relevant, and phase 3 trials of this treatment for NASH are underway right now. There's a second primary outcome, which is improvement in fibrosis without worsening of NASH, sort of the flip of the first primary outcome. And for the second primary outcome, which is for this 1-year study, an improvement in fibrosis without worsening of NASH, the semaglutide had no benefit over the placebo. So the semaglutide improves the NASH, at least in this study, without worsening fibrosis, but it doesn't have a major effect to improve the fibrosis itself. So when we think about the AGA algorithm for evaluating and managing Nafld and NASH, if you talk about the treatment, if the patient's low risk, then lifestyle intervention to improve the obesity and to improve the diabetes and potentially improve the fatty liver disease is always a good idea. But obesity treatment per se is optional. Pharmacotherapy is not recommended, and anything else that would reduce cardiovascular risk is also a good idea. Diabetes care is standard of care. For patients with indeterminate risk, we would use lifestyle, we would use obesity treatment for sure. We would use pharmacotherapy directed at NASH, whether it be pioglitazone, vitamin E, or more recently semaglutide. We, of course, would continue to try to reduce cardiovascular risk in every way possible. And in the case of diabetes care, standard of care, but we'd prefer medications with efficacy in NASH, such as semaglutide. And there'll be others coming up. For high-risk individuals, we want to do everything. We want to institute lifestyle therapy. We want to institute obesity therapy. We want to institute pharmacotherapy specifically for NASH. We want to institute cardiovascular risk reduction modalities. And of course, once again, we prefer medications for diabetes, or we prefer the regimen to include medications that have proven efficacy for NASH. Now, the future opportunities, of course, are widespread. There are interventions directed at preventing or treating the complications of NASH, including fibrosis, so there are anti-fibrotic agents being tested. There are studies of agents to prevent the progression toward hepatocellular carcinoma. There are agents that are looking at other metabolic effects so as to reduce the cardiovascular risk, specifically in this group of patients. And all of those are being developed now, but none of them has demonstrated efficacy. Some of them are very early in development, and we just have to watch this space and look over the next 10 years to see what comes forward. But there are many unanswered questions about fatty liver disease, and I just want to give you a few of them now. Where in the NASH progression pathway is the sweet spot for intervention? Right now, the best interventions are really early on when we're dealing with the obesity and the fatty liver itself, rather than the later stages like fibrosis and inflammation. Do different subgroups of Nafld patients respond differently to each type of therapy? We assume yes, but we don't know how to sort that out yet. Can later stage liver disease be reversed or only slowed or halted? There's some evidence, as I've mentioned, that bariatric surgery in some patients can reverse fibrosis as long as it doesn't get to the cirrhosis level. So even in that study I showed you, F3 patients can see their fibrosis improved. How much weight loss is needed? I said more than 7 to 10%. But we don't really know that. It looks like the more weight loss you achieve, the more the improvement is going to occur. Do drugs or surgery induce improvement in liver disease independent of weight loss? As I indicated earlier, we don't know yet. It's attractive to hypothesize that, but we just simply don't know. And to what degree do anti-obesity and anti-diabetes treatments improve for the cardiovascular outcomes of Nafld? Or are they just simply improving the liver outcomes? Well, we know most of the therapies that we use today, whether medical or surgical, also improve diabetes, also improve cardiovascular risk independent of fatty liver disease. So sorting that out is also challenging. Are these effects dependent upon the stage of liver disease? We don't know. And does improvement in any particular component of liver injury correlate with the cardiovascular benefits? We don't know that either. These are all good subjects for ongoing research. Excuse me. So I'll leave you with a final comment. Nafld and NASH were first described only as recently as 1980, just 40 years ago. 40 years later, fatty liver disease has become a global epidemic, as I showed you at the beginning of this talk. Reducing its clinical impact is a critical component of the fight against chronic metabolic disease. And for most of this audience that focuses on metabolic disease, endocrinology, and diabetes, incorporating the evaluation for fatty liver disease and its treatment into your practice is what you'll be doing in the future. So I look forward to having you embrace this, work closely with hepatologists and primary care providers, excuse me, so that we can get coordinated care that improves the lives of all of these patients. Thank you very much.
Okay, Dr. Nasreen, we have one question for you from the attendee. And he's asking Atorva 40 plus azithromycin versus Atorva 80. Any studies comparing the two dosages?
Yes, there were, of course, no large head-to-head clinical trials, but there are some few observational data, and there are some, pharma-based studies looking at comparing them. Like, for example, there was a study. I can see if I can share my screen and show that. So this is the Valentine Study. The Valentine Study, they looked at the Valentine trial, they looked at the efficacy of ezetimibe in combination with atorva or simva in patients not currently on lipid-lowering therapy. And if you look at this slide specifically, when they compare the addition of ezetimibe with atorva, so these are the green bars, compared with the atorva, which is the atorva monotherapy, which is the gray bar. So when you compare, according to the question, this is the 80 milligram alone atorva, and if you compare it with the atorva combination with ezetimibe, you can see that there is a similar sort of efficacy in LDL lowering, maybe even slightly better for the combination of ezetimibe and atorva. These are the particular dose that he or she asked about. In clinical practice, we do see that sometimes you see really significant differences, occasionally probably the same, but this is most likely what is translated even into clinical practice.
Thank you, Dr. Nasreen. Somebody is asking about also, one of the attendees asking why we are mixing guidelines, for example, algorithm and calculator by HA and risk factor by ESC. So he's asking about mixing guidelines and risk factor calculators.
I'm not quite sure what he or she means by mixing guidelines, but the guidelines are very clear. So, for example, when the slides shown regarding the European guidelines, it particularly talks about the score risk. So they use the score risk calculator, while the ACC use their pooled risk calculator. So each guideline have their own sort of risk calculation. Like, for example, the National Lipid Association, the IAS, they recommend the Framingham risk scoring. We recommended for the region, for this region in the Middle East, the Framingham in our previous paper. And I don't want to talk about the new paper, which is going to be released, but inshallah, hopefully we will see in our new publication on the new updated guidelines. But no, clearly each guideline has their own sort of risk score calculation.
Thank you, Dr. Nasreen. And in that line also, which calculator is more accurate, AHA calculator or score?
Yeah, that's a $1 million question that always physicians ask. Unfortunately, I mean, most of these risk calculators that we have, you name them, I mean, the AHA, the Framingham, the SCORE, Reynolds, all of those, they were not, unfortunately, validated in our region. So we don't have a validation in this particular region, but we try to sort of some risk calculators that might suit our region. So looking at the ethnicity that is mentioned in the Framingham, it gives you that option that you can apply it to this region. And that's why probably was our sort of recommendation. You can go with the Framingham risk for this region.
Again, regarding the risk and guidelines, American Heart Association guidelines, they put people with the risk of 7.5 to 20% will be treated after.
Do you have any question or?
With reviewing risk estimates and risk enhancers. What's the risk estimates? Asking specifically about risk estimates.
Yeah, the risk estimates and the risk enhancers are depending on several factors. So we look at, for example, the age of the patient, family history, smoking history. These are sort of the risk estimates, primarily family history of premature cardiovascular disease. And the risk enhancers are like, for example, looking at the biomarkers such as the CRP level, looking at the LP(a) level, looking at the NKL-brachial index level, and also the coronary calcium scoring.
We have one question from Dr. Khalid Al-Waidi.
Thank you, Dr. Khalid Al-Waidi, for your talk.
He's asking about treatment for high triglyceride and end-stage renal disease. Dr. Khalid,
yes.
high triglyceride and end-stage renal disease.
Yes, Dr. Abdullah. So thank you very much. Yeah, do you hear me? Yeah.
Yes, you are clear. Please go ahead.
Yes.
High triglyceride and end-stage renal disease.
So we know that end-stage renal disease, or actually patients with chronic kidney disease, they are already a high risk for cardiovascular disease. And when we talk about the triglyceride, now we have to differentiate. Is it really a patient with a very high triglyceride, more than 500, that is a risk of pancreatitis? Or do you mean that a triglyceride between 150 and 500? And then we talk about more risk of cardiovascular disease. So if it was for more of cardiovascular disease, then those patients at high risk, they should be started first with the statin, optimize the statin. And as Dr. Nasreen highlighted, we have to choose the right statin and right dose for those patients. Ezetimibe has been shown very well in SHARP trial that can be used in patients with chronic kidney disease. It reduces also the cardiovascular benefits. And then patient on statin and they still have high triglyceride between 150 to 500. Yes, we can treat them. So we have to optimize the diet, and then we can actually use either the fibrate or omega-3. But now most of the studies would really encourage omega-3. It's really safer. Fenofibrate, we have to be careful about the interaction with the other with the medications, and those with patients with high creatinine. If the question was really targeted for very severe hypertriglyceridemia, more than 500, and this is the risk of more of acute pancreatitis, so then yes, those patients, they have really to be treated very well, and we should really start with the diet, with the low-fat diet. Medium chain fatty acids can be used actually to lower the triglyceride. Omega-3 and fenofibrate, they can also be used as well as the statin. The only thing that we really have to be careful about the interaction with those medications. Now, for the statin and high risk, we have also to be really to differentiate. Is this patient was already on statin and now from chronic kidney disease heading toward end-stage renal disease, then yes, we would continue statin. However, if the patient wasn't really on statin from before and now he has end-stage renal disease and already on hemodialysis, then the evidence it is not really conclusive whether to start him or not to start him on statin.
Dr. Khalid, what is the level of like triglyceride when it goes pancreatitis? Which level?
Yeah, it's more than 500 milligram per deciliter. There is the risk, but actually when it is already more than 1,000, that's the highest risk. But on the guidelines, you would see that when we categorize whether it was the European, American, or the endocrinology guidelines, they categorize 150 to 500, and those with above 500. So more than 500, they are really at risk of pancreatitis.
Can I add a question here? Of Professor Ray is here, or maybe Khalid will help us. What about plasma exchange? Where does that fit in your clinical practice?
Yes, that's really an excellent question.
Nobody talked about it today.
Yes, so the plasma exchange, I tell you, the most commonly used that we would see is really the LDL apheresis. So the LDL apheresis or lipid apheresis is really mainly used for patients with homozygous familial hypercholesterolemia and patients with heterozygous severely not controlled with the usual medications. If you see the LDL apheresis is really mainly for LDL and some part of the VLDL. So yes, it can reduce the triglyceride. However, it's only around 20%. This is from our experience from the lipid apheresis unit. However, with the plasma exchange, many people, they have used it in the acute scenarios of patients with severe hypertriglyceridemia and acute pancreatitis. So either they use the hemodialysis or the plasma exchange, but it is really temporarily. But what we have really seen from practice, a patient with a very high triglyceride, usually when they present with acute pancreatitis, so usually by surgeons, they are nailed by mouth, so they are MBO. And then if you start them with a very low fat diet from the beginning, and then you would see within few days that really it would go down. In patients with diabetes, of course, if it is really poorly diagnosed and poorly controlled diabetes, then usually the endocrinologist, they would start with the insulin, and then the amount you start, the moment you start the insulin, actually you would see the lowering of a triglyceride.
Questions for Dr. Nasreen. Thank you, Khalid. What is the indication of imaging without established atherosclerosis vascular disease? So use of imaging.
Yeah, that's a very commonly asked question. And some of the guidelines were actually very particular about that. They explained that in detail. So, for example, if you have a patient without established cardiovascular disease, you might need considering imaging studies, for example, in high-risk patients, like, for example, FH patients. Now, the idea of screening these patients is to look at any occult or early cardiovascular disease in these patients to set your target. So if you can remember the groups that I showed you, we said that if your FH has some evidence of even occult, cardiovascular disease, the target of the LDL would be different. We should be aiming really low, like below 1.4 millimole versus FH without any evidence of occult vascular disease. So in these high-risk categories, you may want to consider imaging. The second thing is that patient who comes like the puzzle for you in the clinic with a persistent LDL that is not 190 and above, that is straight away you go with treatment, but it's in that category or level that you're not confused. You don't know whether to treat or not. So 160 and above, despite lifestyle intervention and everything. And you are sort of reluctant to see if you want to put this patient on a lifetime, statin therapy. And the patients would argue with you even. You just tell them statin, they would start arguing about lifetime statin therapy. So you could consider these biomarkers like the CRPs and LP(a) and ApoB levels. And in addition, the value of coronary calcium scoring is very much talked about now because when you do the coronary calcium scoring, which is a CT imaging, and you receive a zero score, it's sort of a zero score is a very, very reassuring for you that this patient is not at a very high cardiovascular risk. And I can see Professor Ray joining us now.
Do you have any question for Professor Lee, Dr. Nasreen? Yeah. Any question for him, I think?
Yeah, maybe he can also elaborate on the indications for imaging without established atherosclerotic cardiovascular disease.
Yeah, so the main thing I think we think about here is if you've already made the decision to treat, then you don't need the imaging. It's in those people with intermediate risk where you can do one of two things. You can either say, okay, well, we could, for example, you're going to cross the threshold. So if every risk factor stays the same and I just change age, and in 5 years' time, you're effectively going to be on treatment, why wait 5 years? So I tend to use imaging much more. There are a few patients who are completely against medication, and it helps to reclassify those individuals correctly. It helps visualization as well. And one of the most useful things about imaging, whether using ultrasound, particularly carotid, particularly CAT scan, is percentile for age and sex. That is really useful amongst younger people because it means that basically if I do nothing and I'm in the 95th percentile, then for my sex, there are only 5 people with a worse heart than me right now, and that's not going to change, and I will still be in the top 5, and that's not the good 5 to be in. So that's kind of how I use imaging is for those types of patients. The other thing is you can use is for progression of disease. If you've got people on what you think is appropriate treatment, CAT scan doesn't really help there. But there you might use you might use, for example, CT coronary angiography or carotid ultrasound to assess progression of disease. Some people will progress a bit more than others, and then you can be more aggressive or less aggressive with treatment.
Professor Ray, they are asking about what's the minimum starting dose of statin in a diabetic patient for a primary prevention with no contraindications?
Yeah, I think today we would probably use rosuvastatin at a dose of 10 milligrams or atorvastatin at a dose of 20 milligrams. And the rationale is that you're probably getting people to over 40% reduction in LDL with those starting regimens, and which would basically put you into that right in the middle of that moderate intensity bracket. But if you've got long duration of diabetes, if you've got additional risk factors, if you've got microvascular disease, then we are aiming for a 50% reduction. So, and that was one of the things that was done very well in the UK, because, you know, GPs were using very low doses of weak first generation statins. And because of the safety of these drugs, that basically the starting dose at a policy level was 20 milligrams of atorvastatin or 10 milligrams of rosuva. So we never see anybody on lower doses.
Another question.
Yes, I want to go back to hypertriglyceridemia, because in severe hypertriglyceridemia is a very common entity in our
disconnected. Somebody is asking also about patients with hypertension accompanied by high serum CRP. Level of statin drugs to avoid cardiovascular disease risk.
Yeah, so I think that, you know, in terms of hypertension, so if you look at the ESC guidelines, there's extreme elevations of blood pressure, which would put you into a high risk group. So if your systolic's above 180, for example, puts you in an extreme, it puts you in a high risk group. So you should be aiming for 70 in those people. Most people won't have extremes. They will have maybe the blood pressure of 150. And we here in that situation, we need to think about global risk. So if you take 8 variables, age, sex, smoking, lipids, blood pressure, and so forth, you get a 10-year risk. And what CRP is, a bit like imaging, a bit like LPA, is a risk enhancer, because what it's trying to do, the more variables you have, the better your precision is. So again, if, for example, a patient was considered to be intermediate risk and you might delay treatment, if you basically had a high CRP, that would push them into a higher risk group, and therefore that would suggest you might want to treat them a bit earlier.
Thank you. Dr. Walid?
I'm coming back. Sorry, I had cut out. So coming back to severe hypertriglyceridemia, as I said, it is a very common problem in our area, where you actually give the patient all medications. And there are even some doctors, I see them referred to us, they are using fibrates in double doses. And still triglycerides is not controlled. Now, what are the options for patients who are already on a statin, a fibrate? Is doubling the dose of fibrate is an option? Is going more than 4 grams of omega-3 is also an option? And what's the role of the new medications like evenocumab? Then there's a very good study lately with a few numbers where actually it helps severe hypertriglyceridemia. So where is the evidence and where to go with these very difficult to control hypertriglyceridemia? Dr. Ray or Dr. Khalid can join.
So I think my approach, and I'll let Khalid add his bit, is that what is it that you're trying to prevent? I mean, if your triglycerides are above 10, so 20, 30, 40, I mean, I had a cancer patient who, after post-chemotherapy, had triglycerides of over 100. And, with him, for example, the worry would be pancreatitis. And so for those people, you often need combinations of treatment. So fibrates work very, very well and very quickly. We often need 3 grams of fish oils in these people. If there's an acute situation, you think about things like apheresis or plasmapheresis in those individuals. But for most people, we need to think about a dietary component. So the commonest thing in your region will probably be diabetes, and importantly, poor control of diabetes. And the other thing will be obesity, and there's obviously a dietary component. You've really got to focus initially on, I cannot sort of reiterate this enough, there's a lot of this that will improve with weight loss and with really quite aggressive carbohydrate restrictions. So what you're then left with is the risk of atherosclerotic cardiovascular disease. So your triglycerides are carried in particles that will also carry cholesterol. So if you look at the discordance between LDL and non-HDL, because you've got more ApoB containing lipoproteins, that's actually quite high. But that actually also helps us because these people will have this atherogenic dyslipidemia and a low HDL usually because there's an inverse relationship. The global risk is high. So this area, there is no, if you like, clear evidence of one treatment over another. If you believe reduce it, you would say, okay, if high dose EPA was available, then I would use that. There are some concerns about if the benefit is exactly 25% or more modest because of the control group, but I suspect that there is some benefit, but not as much. It won't change the triglycerides. Probably you're not worried about pancreatitis, you're worried about risk. I am a lot more comfortable with reducing atherogenic lipoproteins and by having more LDL receptors. Therefore, in these individuals, if I want to achieve non-HDL goals, if I want to achieve ApoB goals, essentially the addition, you could add in ezetimibe, but the addition of a PCSK9 directed therapy gives you huge reductions. So I think I wouldn't use an anti-PTL3. The costs will be prohibitive. Also, we will potentially be testing that patient group. I think we also need to wait for the results of the prominent trial as well. So prevent extremes of pancreatitis, then, and that's very aggressive, triglyceride directed lowering. The triglyceride is the thing you want to stop. Below a certain level, you're thinking about it as a marker of ASCVD risk, and your approach is different.
Thank you, Professor Ray. We have a specific question about familial hypercholesterolemia. They're asking about genetic studies, is it required? And the second about treatment of in pregnancy and the choice in pregnancy.
Khaled, do you want to take that? Or Nasreen or anybody?
For FH, they're asking, familial. So FH, they are asking about genetic studies and pregnancy treatment.
Yeah.
Anyone.
Yes. So for the FH, actually for the genetic study now, what we are doing, it depends if the family has been screened. So what we are doing now for any patient with a high probability of FH after we do the Dutch lipid criteria network. So yes, we do already screen currently in Oman and in the Gulf. Actually, we have done also the Gulf FH study. So we do screen for the genetic causes. And once we know the genetic cause, then the family we can use the cascade screening. So we just can look for that mutation. And I think it's really very important in our area now actually to do the genetic testing, especially if we are highly suspecting an FH. You know that we have a very high rate of consanguinity in our area. So it's really very important. And by knowing actually the patient FH, as Professor Gossick in his presentation, he said the earlier you detect those patients, the earlier you can start them. And in our region, actually, it applies what he has presented, that it is really underdiagnosed and undertreated. And we have seen many patients with FH, heterozygous FH at the age of 40, 45, not yet diagnosed. So personally, I really encourage to do the genetic testing for FH in our region. For the patient in pregnancy, you know that we don't give the usual medications, that is the statin and the ezetimibe. In Oman, for pregnant, we have the LDL apheresis, and actually any patient with non-homozygous FH she is already on On LDL apheresis, we really continued, and we did actually, we published one paper in one homozygous FH pregnant. It was her 4th pregnancy. She was the age of 40. So we said, no, she is a very high risk, then we have to continue the LDL apheresis, and we continued until the week 36 weeks of gestation. It was very, very safe. However, it was multidisciplinary approach. We have actually the cardiovascular surgeon, we have the high risk obstetrician, the lipidologist, together treating those individuals. So that's really the treatment what we use. But then I think Prof. Ray can also comment on PCSK9 in pregnancy.
So for homozygous FH, I mean, essentially with all of these therapies, you're using clinical discretion. So I know that, for example, we've seen people around the world essentially after the first trimester, potentially now, because their cholesterol levels are so high and they've got a history of atherosclerotic cardiovascular, these are the homozygous patients actually using MABs. These are large drugs and they are less likely to cross the placenta. So basically, with that in mind, having explained risks to patients, that has been something that's been done. For heterozygous FH, going back to something that Khalid said, it's absolutely important to get the genetics right. And the reason is it's so easy. The costs are coming down. The more we use it, the more the costs will come down. It's a genetic disease. Your whole thought process and management will change considerably. I mean, at the moment, we are getting the 1800 variations for FH. What we should be doing is any patient with an elevated cholesterol is looking at autosomal dominant, familial hypercholesterolemia, and also the polygenic score, and also LPA, because you're going to find a mixture of these three. Now, your approach is very different. Telling a patient that they've got FH means that you can start thinking about their kids earlier. And if you find their kids earlier, you don't need 4 or 5 drugs. We generally need more drugs later on because we've missed half of their lives already. That's the problem. So you can start with cheaper, commonly available, they've all been tested in kids, and move forward. And if needed, add in other things. The thing about women in particular is we know there's a period of time that they will not be exposed to statins because they're trying to conceive or they're breastfeeding. And that was one of the questions that was asked. So what you're buying is a legacy effect of early treatment to basically not worry during those 2 years. And if somebody wants to have multiple pregnancies, for example, with good counseling, you can say, stop the breastfeeding. When you're ready, put you back onto statins. Should you become pregnant, we stop it immediately. But before you actively start, let me know, and then we'll make sure we stop the medications a good month or so before. So it's just basically good communication, in that regard.
Yeah, and may I add something about the genetic testing? And I think it's very important. It's gaining a lot of interest right now, especially in this region, given the high consanguinity rate. It's very important to consider that. And having the Gulf FH registry right now with the excellent pool of data that we are gathering from our patients, we are reaching now to this phase 3 of the study of the registry where we're going to be doing the genetic testing. And it's very important to understand sort of the prevalent genetic mutations pertaining to FH. And like Professor Ray said, this is like the future for, target specific therapies in the near future. So let's say I would know that this particular sort of genetic mutation that I have, and you would have sort of a directed therapy in the future. So for the children, for the new generations to come, even though it's not a must, keeping in mind some of you are in clinical practice, you might have difficulty in accessing genetic labs, or it might be sort of a financial burden for some of the patients, not covered by insurance or not covered by the government. All these factors need to keep into consideration, but having the genetic testing would add to the confirmation sort of the diagnosis and for the future perspective of therapy.
If I can add as well, I mean, so most of my useful ideas I get from seeing patients and clinical problems and dilemmas. And, you know, recently there were at least 2 patients who were in their 20s. And, you know, we've got into the habit of doing quite a lot of genetic testing, and certainly they were below the threshold, but it was just their family history and everything else. And even though their LDL was below 4.9, and I've been surprised, there are at least 2 with LDLs of about 4.2, but with an LDL receptor mutation, you know, that's been picked up. And this is the impact of age. So, I mean, everybody here on the screen at the moment is involved with the FH Studies collaboration, and we'll have the genetic data cleaned, hopefully by the end of this year. So one of the things I'm hoping that we will do is actually be able to reclassify, because one of the things I'm not happy with and I think is wrong is basically the Dutch Lipid Network criteria has to be recalibrated for age and gender. That was great when it was done. And the reason I say that is if you look at our data for women and men, women, by virtue of the fact that there are other factors as well that may be protective, will have less cardiovascular disease. So think about this. So if I have a man with FH, genotype positive, I could potentially have their child, their offspring, with lower cholesterol levels, you know, because they're in their 20s. If I just go on cholesterol and don't genotype that patient's got a 50% chance of being a carrier and actually being affected later on in life. Because of the inherent nature of lifespan, gender, and protection, that person may, you know, end up developing cardiovascular disease later in life. So that thinking, that trigger of could this be FH may well be missed, and cholesterol levels have crept up. And that person's had 3 children. She's passed on those genes, and let's say they're all male. So now in that situation, because I've missed her, I'm going to miss the chance in 3 grandchildren. And that is why genetic testing for hypercholesterolemia is absolutely essential. You know, we can get to not 0 risk, but we can actually get to almost 100% prediction if we actually just follow this through. We need one approach for those people alive and around that we've missed. They're walking around in their 40s, 50s. And we need a different approach for those yet to be born or those that are early in their life course.
Yes. Great. Great discussion. And I think this is needed, the family planning and family trees, and this is need lots of support, especially I think from governments, because the tests are very expensive, as Dr. Nasreen said. I think we're going to conclude our session today. Thank you, Dr. Ray, Khalid, and Nasreen, for your interesting and very excellent session. And we're sorry to miss Dr. Kaplan. So we're going to move on to the next session. Thank you for being with us. Thank Dr. Abdullah, my co-chair, and thank you for involving us tonight, and see you later.